Part of the abdomen which is called retroperitoneum, where are localized very important structures like kidneys, collecting and outflow system for urine, and also adrenal glands. Partially we will touch also to vessels, lymph nodes, etc. So first topic is kidney. Kidney in Latin ren, and then the adjectives like renal, etc. So kidney is the organ which is primarily localized in retroperitoneum. So this organ is developing and staying in retroperitoneum in comparison to duodenum and pancreas, which are developing in the free peritoneal cavity covered partially by peritoneum. So kidney is not covered by peritoneum because it is a primary retroperitoneal organ. The kidney is lying in the space between about TH12 and L4. The right kidney is a little bit lower because of pressure of parenchyma of liver. Depending on the size of a liver, the kidney could be shifted also more down when liver is extremely enlarged. Upper 1/3 to 1/2 of a kidney is in some touch to diaphragm, to the dome of diaphragm. Especially important is dorsal pleural recessus, which is in about 1/3 behind the dorsal aspect of a kidney. This space, pleural cavity, is important for the spread of the infection. Typically infection from a kidney to the pleural cavity, it could be irritated. And also important this recessus is when you have to perform the drainage of a collecting system, and when the kidney is in deep inspiration, kidney is going down. When the patient is expiring, the kidney is traveling up, and then during a very deep expiration, the kidney could be covered from dorsal part mostly by pleural recessus. So it's a very important. The second topic relation is with the liver. This is kidney, and between liver and kidney we have a space which is called hepatorenal. It's a pouch of a peritoneal cavity in which could be fluid, in which could be the spread of the tumor in peritoneal cavity, and this is a barrier between kidney and liver. It is a very rare when a pathological process from kidney or from liver growing to the other organ. So about kidney. Kidney or kidneys are localized in retroperitoneum. They are lying on the dorsal abdominal wall, and dorsal abdominal wall is made from muscles. Here we can see the largest dorsal muscle, which is psoas major. And psoas major is a framework on which we can observe the hilum of the kidney and medial aspect of a kidney. Kidney in retroperitoneum is covered, like seen on the right side, is covered by fatty tissue, and it's covered anteriorly by peritoneal coverage, and peritoneal layer is a dorsal wall of the peritoneal cavity. So then kidney is a dorsally, and then the name retroperitoneum. So it's a retroperitoneal organ. The kidney is in very close relation to adrenal glands, which are localized on the upper tip of a kidney, and kidneys are connected with the great vessels in retroperitoneum. Their blood supply is from aorta and inferior vena cava. But nothing is in medicine in 100%. You can see that it is a very variable blood supply to kidneys. Size and weight of a kidneys. In normal situation, adult, the kidney has a length about 12 centimeters. So it's a very important, the size, because when you have to assess the kidney and the state of the kidney, you perform very easy measurement. It's a craniocaudal length of the kidney. It could be made by ultrasound. The weight is about 150 to 180 grams, and this very high weight is according that the kidney is full of tubules, full of vessels, and all those structures are filled by fluid, which has the approximately the same or a little bit higher weight than the water. So kidney is not containing free fatty tissue except sinus. So this is a size and weight. The kidney is localized dorsally in the abdomen and is lying very close to back. And kidneys projections to the surface of the body could be made then. You can palpate distal ribs. 12th rib is palpable dorsally, and in medial aspect of the back you can then perform something which is very important in clinical medicine, and the maneuver is called tapotement. Tapotement is a hit with the edge of your palm to the back, and this vibration of a back could induce some pain in a lumbar region, and also it could cause the pain which is irradiating into the groin and into the medial aspect of a proximal femoral region, or in scrotum or labia majora in women. So then this is the irritation of a capsula of a kidney, and this maneuver could assess the pathological process. So the hit is somewhere below 12th rib. The kidney is lying dorsally on muscles, and those muscles are diaphragm, musculus quadratus lumborum, transversum abdominis, and medial, as I said, medial is psoas. You can see that on the psoas we could see this structure. This structure is a pelvis or part of pelvis and ureter. And then pathological processes which are affecting collecting system, proximal part of collecting system very frequently, could have some consequences on psoas major. It could be irritated, it could be edematous, and it's very important that this hilum is lying on the psoas major. Kidney's position in retroperitoneum is in the space between peritoneal cavity and here muscles. This is a psoas, quadratus lumborum, and transversus abdominis. If you remember from the lecture about abdominal wall, here we have some layers. This is a layer which is called peritoneum. Then it's a extraperitoneal fascia. And this is fascia transversalis, transversal fascia. This green one. From a green one is one layer which is then splitted into two sheaths. One sheath is ventrally and the second is dorsally. Ventral part is called gerota fascia. And dorsal, I hope that you are remembering, Zuckerkandel. Those are two sheets, pars anterior and posterior, of a renal fascia, and fascia renalis is delineating a space in which we can detect next fatty tissue, which is a perirenal, and this is called capsula adiposa. Capsula adiposa is a fatty tissue in a bed of a kidney. And directly on the surface on the kidney, we can observe a glossy, thin membrane, which is called capsula fibrosa. So then, kidney is delineated from peritoneal cavity by peritoneum, extraperitoneal fascia, and renal fascia. Renal fascia is fusing with counterpart from the other side anteriorly and is fusing with connective tissue in a prevascular space, and here is a fusing with the gerota fascia, which is going from the other side. Dorsally, Zuckerkandel fascia is a fusing back with the transversal fascia, which is covering the anterior aspect of the muscles of the abdominal wall. Here, the muscles of posterior group, which contains psoas major and quadratus lumborum. So, in the region of psoas is fusing this dorsal sheath of fascia renalis and fascia transversalis. So this is a very important aspect which has its consequence. The fascia renalis forming the sac which is closed at the top because there is a diaphragm and is making two sheaths, anterior and posterior, and kidneys inside. Laterally is effused, and medially you have great vessels. Then caudally you can observe an opening, and through this opened caudal aspect of the renal fascia, the kidney could move down and up. It has a very important consequences. It's a normal during breathing. The excursions of a kidney are very limited in a normal situation, but you can imagine that a patient with weight loss and with weight loss could have very decreased or completely disappearing the fatty tissue in the renal fascia. So the capsula adiposa is decreased in its size and volume, and then a kidney is more free in motions, and then something which is called ren migrans, migrating kidney. The kidney could then, in upright position, travel down, and when a kidney has a quite long or long bowing vessels, the kidney then could change a position and travel down and could be up to in the pelvic region. So this is a migrating kidney, Ren migrans, then it's important that you can see long vessels, but they are originating at the region about L1. It could be seen in ladies with problems with food intake, or also male, and also it could be in patients who are treated by the treatment for some malignant disease, or patients with malignant diseases, etc., etc. So this migrating kidney could lead to the compression and sometimes kinking of the collecting system. So this is Ren migrans and fascia renalis. Here we have 2 CT images in one patient documenting the position of a kidney. This is the liver, this is the right kidney, this is the left kidney, and the fascia renalis here in the upper part is quite small, and this is the carota fascia. And dorsally is Zuckerkandel. More down, the space where kidney is in a fascia could be seen here. And this is a space which is a capsula adiposa, and on the surface of the kidney is a capsula fibrosa. So this is a retroperitoneal position, and I have said that there is a very close connection to psoas major. This is also psoas major, and here we have quadratus lumborum. So when something is happening in pelvis, here or here, you can see that this is a very, very close connection, close relation to those muscles which are dorsally. Superficial structures, superficial description of kidneys. What's important? Kidney is on the surface glossy, but it is not peritoneal coverage. This is a capsula fibrosa. This capsula, when it's cutted, could be then peel, and also the parenchyma of a kidney is a glossy. On the top of the kidney, we can observe the tissue which is called adrenal gland, or glandula suprarenalis, or adrenalis. So it's a different organ. It's splitted from kidney by thin layer of connective tissue. And we can distinguish anterior face, facies anterior, facies dorsalis, lateral margin and medial margin. Then this structure, this is the gate to the kidney, but here is called hilum. And in a hilum of a kidney, we have a constant position of the structures. More anterior is a vein, in the middle is artery, and dorsally is a pelvis. So the pelvis is the most dorsal structure. Then the approach for surgery is from dorsal part, from retroperitoneum. So please remember that the anterior structure is a vein, then artery, and then pelvis. So the description of a kidney from the point of view of surface is very easy. It's a Very, very easy. So, inner structures of a kidney. When the kidney is cutted, you can buy a kidney in a supermarket because there's available there some pig kidney, and when you cut it at home, you can see that the inner structure of a kidney is made from two kinds of the tissue. One is a little bit lighter, so it's not too dense in color, and this is structure which is called cortex. Cortex is containing mainly the functional structures which are called corpuscula, Malpighi, or glomeruli. This kidney tissue, but is going inside in structures which are called columna, column. Column has the same structure like the cortex, also mainly made from structures which are called glomeruli. On the opposite side, medulla. Medulla is forming the structure which is very similar to pyramid, or is a conic structure which ends with this part which is called papilla. On a papilla we can see small openings of ducti, and those ducts are leading the urine to the collecting system. This is the own parenchyma of a kidney. So on the surface is capsula, then we have a cortex, and in cortical structures containing also columnae are pyramids, and those pyramids are then they are in a contact with the structure which is called calyx. Probably here it could be epsilon. Calyx minor is the smallest part, the proximal or the most proximal part of a collecting system, which is fitting to papilla. Then more calyces minores, small calyces, are together forming calyx major, large calyx. Calyces forming some groups, typically superior, medial, inferior, and they are fused into the structure which is called pelvis. And a pelvis then, which is here, is then following to the last part, which is called junctio ureteropelvica or ureteropelvic junction, where pelvis is continuing to ureter. Those structures here are called collecting system. And this is parenchyma. Why it's important? When we have an international classification of diseases, and you will see to the classification of the tumors of a kidney. Tumors of a kidney are divided in two main groups. Tumors of a pelvis and the tumors outside the pelvis, or except pelvis. So then the tumorous processes which are arising from parenchyma and pelvis are very different from the behavior, especially behavior. So this is structure of a kidney when it's cutted. I have to note here one important term which is called sinus. Sinus is a space which is inside renal parenchyma. It's something like free space which is filled by fatty tissue, but it's a bed for pelvis and vessels. And here you can see that the fatty tissue is also outside, also inside, and the invasion of a tumor in the sinus is very similar from the prognosis of the tumor, like when the tumor is growing outside, growing into the fatty tissue. So remember that in sinus we have a fatty tissue and it's the outer space of a kidney. So it's a groove inside in which is localized pelvis. Kidney has this shape, kidney bean-like shape, but it's true not in 100%. If we could talk about liver, liver has a minimal variance, minimal variability in the size, minimal variability in the position and shape. But a kidney could have some anomalous position, shape, and number of kidneys. The most popular and most known variant is called horseshoe kidney, because it is really has the shape like horseshoe. Yeah. But we have other fusions of a kidneys. Kidney could have position on the other side, and then we have a fusions, very frequently fusions of a kidney could be on the other side and could migrate. The left could be on the right and could be crossing the right-sided kidney. Ureters could crossing or could be parallel, or the kidney could be also rotated into the completely different position with hilum facing lateral part of the abdomen, could be in those L positions, or could be like here, fused. And also they could be localized in the pelvis. So those anomalous positions very frequently are associated with anomalous shapes. So when we have renduplex is frequently that we have two kidneys on one side. They could also fuse. When the kidney, duplex kidney, has the second which is rotated to the other side, and one hilum is this way, the second is this way, then it is called sigmoideus. Sometimes kidney in a midline could be fused, and they could have the fusion of upper and lower poles, and in the middle we have two hilar structures. This is called rendiscoides. Then we know the horseshoe kidney. Horseshoe kidney is a kidney which has two hilar structures and lower pole is fused. Sometimes could be only the fibrous band, and also it's a horseshoe kidney, ren arcuatus. And the last one is L-shaped kidney. L-shaped kidney is like this. Why the variability is so frequent? Because kidney is developing from the multiple somites, and the fusion of the segmental parts of metanephros could lead to this sometimes very strange, bizarre variants. It's in reality. It's one patient, and this is L shape. This is also CT of it. I have said the hilum is facing midline, and it's a little bit more anteriorly deviated from frontal plane, but here in those anomalous kidneys, very frequently you can see that the pelvis is looking to the anterior side, and then also the patient could have some problems due to course of a ureter with the outflow and also backward flow of the urine. Then those patients could have very frequently chronic infections of those kidneys. The most known horseshoe kidney is seen here, and horseshoe kidney we can observe like a side finding when you perform ultrasound of the abdomen. This is a lumbar vertebra, and this is a kidney, and this is a bridge which is fusing lower poles of the kidneys, and you can see a band of a tissue in the front of lumbar spine. So this is a horseshoe kidney. I have described the inner structures, the macroscopic differences between capsular and medullar part, but the kidney is a very complex gland, tubular gland, which is able to create the excrete which is called urine. Urine is full of waste products, also is containing some physiological substances which are needed for normal function of organism. Then the kidney could concentrate or should concentrate those waste products in the urine and to decrease the concentration of those substances which are needed and which are used by the organism. The functional unit is called lobus renis. Lobus renis is a part which is seen approximately here. Lobus renis is a one functional unit which is then divided into lobuli, and the smallest unit which is functional is called nephron. Nephron is a complex structure which starts in the cortex or in column and then is made with two tubular structures and finally is able to excrete the urine into the collecting system. Nephron is made from corpusculum renis malpighi, which contains glomerulus, then capsula, and from capsula is rising proximal tubulus, then it's a Henle loop, sorry for this check, Henle's loop. After Henle's loop, it's a distal tubulus, then definitive urine is going to tubulus colligens, and from ductus papillaris, the urine is then flowing through the papilla to the collecting system. So, in parenchyma renis, we have two main substances, cortex and medulla. Medulla is stripped, Medulla is stripped towards to the center of a kidney. The stripes are converging to the papilla. Glomerulus, Bowman's sac, and tubulus proximalis, proximal tubule, are cortical structures. Henle loop is then, this is a proximal part, this is a glomerulus, and here we have a proximal tubule, this is a Henle loop, and Henle loop is in medulla. And then the distal tubule is back going to the cortex, and it's going to ductus, tubulus colligans, and from tubulus colligans it's going down the urine to the ductus papillaris and then to the calyx. So this is a very, very complicated structure, and the first point where the urine is created is corpusculum renis Malpighi. This corpusculum mirabile, like it was described by the Malpighi, it contains this structure, which is a very complicated notch of or node of vascular structures. It contains vas afferens. Through the vas afferens, the blood is flowing inside, then is going through this rete, and then is going outside from efferent arteriole. In the glomerulus inside, we have cells which are covering the vessel, and those are podocytes. They are flat cells which are on the inner sheath of a capsula. The outer sheath of the capsula is called Bowman capsula. And in Bowman capsula is an opening which then is opened to the proximal tubule. So what is happening here? When the blood is flowing through the vessel, the primary urine is ultrafiltrated through the pores in the arteriole or capillary structure. And then primary urine is collected in Bowman's sac and then is flow outside the glomerulus and outside the corpusculum renis into the proximal tubule. Here is a nicely described or this structure. So this is glomerulus, in which the urine is created. Then the urine, primary urine, is going into the tortuous proximal part of the tubule. Then there is proximal stride part, and it's a so-called thick segment of a Henle loop. Then it's going to the medulla. A Henle loop is going back, and tubulus distalis, distal tubule, is leading urine back near to the glomerulus. And here is a convolute distal part of a loop, and here the tube, small tube, is then fused with other one, and here we have a definitive urine. So here we have a blood, then here primary urine and definitive urine. When we can see the production of a kidney, the amount of urine which is created during one day is how many milliliters? Do you know? No, definitive urine. Yes, 1.5 liter. And amount of urine which is made by one glomerulus is 100 milliliters a day. So if you can compare when we have a 10,000s of glomeruli, that resorption of a primary urine is more than 99%. So it's very important that the structure, complicated tubular structure, is very effective in back resorption, mainly by water, but also with other substances which are filtrated into the primary urine. And this is the reason why it is so complicated, because due to osmotic, and you will know something about it in physiology, that there are many mechanisms how the urine is resorbed in a medulla. And mainly it is due to osmotic changes here and different thickness of a loop wall. So this is a excretory system for external excretion of urine, but we have also very important apparatus which is called juxtaglomerular. This juxtaglomerular apparatus is made by two different structures. Here we have an afferent vessel, and here we have cells which are called juxtaglomerular. Those juxtaglomerular cells are able to excrete renin. Renin is a cytokine or local hormone or global hormone which is able to cooperate with angiotensinogen and forming the complex. In a physiology you will know about it, renin-angiotensin, which is able to handle with is able to increase blood pressure. What's important here? The blood pressure, the proper blood pressure is needed for creation of the urine, because when the blood pressure decreasing, then the pressure between vascular space and space which is between Bowman's capsula and vessel is decreasing, then there is no pressure to create primary urine. And this is a very effective method when the systemic blood flow or the pressure in a renal vessel is decreasing. It could be systemic decrease of a blood pressure, or the blood pressure could decrease when the renal vessel is stenosed. When the decrease of the blood cause decrease of blood pressure, it could induce renin secretion, and then the renin secretion is able to increase systemic blood pressure. And it's a very important mechanism how to patient could have hypertension. It's one of the mechanisms which is important in pathophysiology of blood hypertension. So it's renin. Then we have here also mesangial cells. Mesangial cells are cells which are localized in between glomerular vessels, and also other mesangial vessels are seen here between so-called macula densa, which is a part of a distal metanephric tubulus, and this vas afferens and efferens. And those mesangial cells are able to produce prostaglandins and peptides. Those prostaglandins and peptides are able to maintain other functions, but also the secretion of renin. So the corpusculum renis has its own controlling system of blood flow. This control of blood flow is important because in a kidney, like in a brain, we can see blood flow also in diastolic phase. So it's a diastolic, systolic. When you can observe the blood flow in a muscle, in a muscle is blood flow only, or mainly only, in a systolic phase, and the blood flow during the diastolic is almost zero. But in a brain and a kidney, due to functions, due to consciousness, due to renal excretion, is needed to have also this diastolic blood flow. So and this diastolic blood flow is maintained by this juxtaglomerular apparatus. So kidney functions, I can make some conclusion that it's a gland with exocrine secretion, which is in corpusculum renis. The filtration of primary urine is about, I have said, 200 milliliters a day in one glomerulus, and in following sections, the reverse resorption, and you can see, and you will see it in histology, that there are cells which are able to resorb then natrium, chloride, also amino acids, glucose, and other important substances. Then, somewhere here, you are in the situation where the water is back resorbed because it's here different osmotic pressure, and the definitive urine is then going to the distal part and going outside into the collecting system. Important function of all those parts is not only resorption but also active excretion back, except the primary urine. Something could be actively transported into the urine. And we have very important cooperation with two endocrine systems, aldosterone and antidiuretic hormone or vasopressin. Antidiuretic hormone is a hormone of central nervous system, which is excreted to the blood by the neurohypophysis, and aldosterone is a hormone of adrenal gland. We will talk about it this lecture also. Then we have some endocrine secretion, and the endocrine secretion is important for renin. Renin then is able to perform vasoconstriction, so to increase the blood pressure, increase the blood flow in a renal riverbed, but also kidney is excreting second interesting substance, which is also hormone, which is called erythropoietin. Did you heard about it? Yeah, it could be sometimes could be heard in broadcasting that some sport active people use or abuse erythropoietin. So it's a very frequently abused in bicycle rides, etc. But erythropoietin is a substance which is able to stimulate the creation of erythrocytes in bone marrow, and also it's able to decrease the apoptotic destruction of precursors of red cells. It's very important to handle with the level of hemoglobin related to the altitude. So we have some level of hemoglobin, but those which are living in Tibet or in Mexico or in Chile in very high altitudes, they have a more count, a larger count of red cells. So this is caused by erythropoietin. So the function of a kidney is depending on the riverbed. The riverbed is very special in a kidney, and kidney vessels are a renal artery and a renal vein. So those are main suppliers of kidney. We can here also use the rule that the vessel, artery and vein is named by same way. So then it's easier. So then we have an artery which is called interlobaris. Why it's called interlobaris? Because this is a lobus of the kidney. In interlobularis artery, which is seen here, which is in one lobulus, you can observe this bowing artery which is going this way. And the second is going this way. And then it's very important, those are arteries which are called arcuate. This is arcuata. It is arch of arteries. But what is drawn here, this is important, that there is a barrier of territories. They are not connecting. They are so-called ending arteries. This arcuate artery then has lobular arteries. You can see here those lobular arteries. On those lobular arteries are glomeruli, but also finally you can see some capsular arteries, but also they are so-called radiate arteries, which are radiating in a kidney cortex. The second arterial system is then going into the medulla, and those medullary vessels are called recta. And vessels of a kidney have different functions. So this is a filtration. But those which are in medulla is a resorption. Especially water. So this is a different function of those kidneys. So in territory of arteriola recta, there is no glomerulus. Glomeruli are in the territory of arcuate arteries. So those are vessels. So please remember that those vessels are ending, so they have no anastomosis, no possibility of collateral circulation. So then, when you can imagine that some vessel is occluded, Typically, it could be due to embolization. It could be also due to trauma. It could be also caused by some infection of a kidney. And when you have here this vessel occluded, then the whole territory is then ischemic and forming infarction, forming a scare after infection, etc. So it's a little bit similar to spleen, because spleen has also ending vessels. It's a not functional ending, it's a real ending vessels. Yes, your question.
Do we only have two arcuate arteries or one more?
Two renal arteries?
Two arcuate arteries.
No. Arcuate arteries are multiple. Arcuate arteries are here. This is an interlobular artery which is divided in two, and two arcuate arteries supply one lobulus. But in every lobe, you have a system of those arcuate arteries. They are not only one, but only two. They are not fusing in their territories, so it's important. For your information, the ultrasound and Doppler ultrasound of those arteries is very important when we assess the function of a transplanted kidney. We are able here to observe the blood flow, the typical blood flow which was seen on the previous slide is for normal functions. When we see some changes in blood flow, it could be a sign of some failure of a transplanted kidney early, several hours after transplantation. So those arteries are very also important for the assessment of a real perfusion and real function of a kidney. So it was almost microcirculation, but we have to discuss also the variability. I have described some variability of a supply of a liver, but it is not too broad variety. We can say 3-4 variants. But here are some schematic, and when you add all those, so you can say that about 60% of patients could have one right and one left artery and vein. The other are here. We talking about polar arteries. So this is upper and this is a lower. Those polar arteries could arise from a stem of a renal artery like here, or could arise somewhere here and somewhere here separately from aorta. Again here, the development of a kidney from several segments could cause this strange architecture. Then we have multiple arteries. Multiple arteries could be 2, 3, 4, 5 for one kidney. So up to 5 per kidney. And then when you estimate that we have 2 kidneys, and each kidney could have a different vascular supply, so the combination, when you have really this, so 60% has one kidney, one artery, one vein. So the combination is very important. Why it's important? I have noted that we have a kidney transplantation. It's one important thing. Then it is a surgery. Surgery for kidney tumors. Surgery for abdominal aorta. Because we said that territory of the artery is ending. So when you ligate this artery, or is occluded, 1/3 of a kidney losing function, then it's important to describe properly the anatomy before surgery to know where the vessel is. The second important thing is when the surgeon, this artery has about 1 millimeter. That's about 3-4 millimeters. And when I am not describing this artery or vein, and a surgeon perform resection, ligation, remove kidney, what could happen? The rupture of this artery in the time of surgery is not too important complication because the physiologic mechanism in the injury of a vessel is a contraction, and the spasm of a vessel is able to close the artery, and no bleeding is in the period of surgery. The surgeon is closing the abdomen, closing the retroperitoneum without any symptom of a bleeding, but after hours, this is again opened, the spasm is releasing, and then the bleeding could occur. So this is the reason why some danger situation could occur when the artery is not ligated. So this is the reason why we perform the assessment of a vascular system of a kidney. So here you can see the CT angiography. Those are arteries and veins before surgery. And here you can see that the patient has a duplicated kidney, and one artery is arising from distal abdominal aorta, one here, and also here you can see branching of arteries, and here is a cyst which was compressing pelvis. This is this cyst, and you can see also very complicated vascular drainage, venous drainage from the kidney. So please remember that anatomic description, renal artery and vein, but in reality, the variability is very, very high. In one kidney, only 60% could have one artery and vein. The second important thing is that kidney has its segments. Segments are important, yes, one.
When you talked about the different shapes, the different modification of kidney, the function is the same as in normal kidney.
Yes, the general function is the same, but it is prone to infections, and infections very frequently, pyelonephritis, could lead to decrease of the kidney function because during aging we lose our glomeruli. I have about half nephrons than you. In 80, it could be 30%. But infection and inflammation, all those processes could reduce the number of nephrons. So then, those kidneys are prone to have a decreased function, not due to different structure inside, but due to secondary changes during some disease. So renal segments. Renal segments are very important in surgery. I have said that the territory is ending, so then one segmental kidney artery, you can see here, typically we can see in a kidney 5 segmental arteries. But those arteries could divide in a hilum, but I have described that we have a polar, and typically we have a epices. They are one and second segment, and then we have one anterior, second anterior, superior, middle, and then we have one segment which is a dorsally. So apex, inferior, superior, middle, and posterior segments. So those segments could be then resected by the surgeon. If you can imagine, when the patient has a new tumor, and the easiest surgery is to remove the whole kidney, but then you lose all your nephrons of a kidney. Then our approach today, the modern kidney surgery, is when the patient has a smaller tumor, then surgeon is resecting or is able to resect also one segment, the middle segment. So this is important to know how the arrangement of segment or segmental artery is. So it was kidney, the own kidney. Then we have a collecting system. Collecting system is collecting urine and is enabling outflow of urine outside from the kidney to the urinary bladder, then through the urethra outside from the body. So it's removing waste products from human body. The first part are called calyces. Calyx minor is the smallest, which is facing papilla. Then they are connected to the calyx major, larger calyx, and then is created pelvis. Pelvis has a cone-like structure. It's a cone-like structure. It's a localized dorsally from vessels. So this is point of view from dorsal point. And then this pelvis is localized dorsally from vessels, so surgeons have to use dorsal approach. Collecting system is very important for the maintaining the function of a kidney. The urine is created in kidneys. You can see here contrast agent. It is one of the substances which is then concentrated in urine, and here is outflow in an X-ray, which is called it's a intravenous urography. Important pathological situation could be tumors and hydronephrosis. Hydronephrosis, what is hydronephrosis? If there is some blockage of outflow from the kidney, the collecting system is then inflated, enlarged, and what could happen? We have said that we need pressure in the blood to be filtrated, but we don't need only pressure. We need overpressure. So when you have an increased pressure in a collecting system, then the renal functions are reduced and also the perfusion is decreased because you need higher pressure to maintain the same perfusion like before. And to document this, you can see it here on those two kidneys. Here is typical patient with acute hydronephrosis, and you can see decreased density, decreased white color on the affected side, because blood flow and contrast agent is not too much enhancing the kidney parenchyma. And also inside the whole collecting system, you can observe some pathological processes like infections, like tumors, and what's important, because there is no valve, nothing between kidney and urinary bladder. We have free way of a spread of an infection and free way of spread of tumors inside this holes. So it's important. Renal pelvis could have different shapes. We have two main, dendritic Dendritic is typically like arborizate, so dendros, arbor, tree-like. And on the opposite side is ampular-like. So more conic, more spacious. And in between is something like this. So those anatomical variants are also imparted in resections of a kidney. So from pelvis, the urine is flowing into the ureter. Ureter is tubular structure which is in about 30 centimeters long, and then the width of the tube is about 6 millimeters. When it's larger, more diameter than 6, it is called hydroureter. So hydroureter and hydronephrosis are dilatations of collecting system. It takes two parts. The borderline between them is here. We know that borderline between pelvis and abdomen is the line of iliac arteries and veins. The superior part of ureter is called abdominal, and it is going to apertura pelvis superior, then it is crossing here arteries and veins, and then it is entering pelvis, and then going medially, and it is opened to the urinary bladder. This is called pars pelvica. In urinary bladder, we have a portio parietalis, parietal portion. That portion is a very short and is going obliquely through the wall of a urinary bladder. And we will note why it's important. The ureter, which is going into the pelvis, going a little bit different way in a woman and in a male patient. In a woman, it is crossing the structures which are also seen here, and it's a ligament which is called ligament teres uteri, and also it is crossing this band, which is also seen in a male, which is oblique umbilical cord. And in male, it's important that ureter is crossed also by ductus deferens. So, ureter is a tube, and the wall of ureter is like in tubular structures made by mucosa, tela submucosa, which is loose connective tissue. Then we have a tunica muscularis. In muscular layer, we, in comparison to GI tube, we have outer circular and inner longitudinal layer. It's a different because this is vice versa to GIT. In GIT, inner is circular, outer is longitudinal, and outside is adventitia, so connective tissue which is continuing to the surrounding connective tissues. Important is that we have some natural stenosis, natural points where we could observe typically stone which is here in contraction during passage of stone retained, and the pain which is associated very strong and undulating pain is called colic, renal colic. The stone is then traveling from the calyces or pelvis, and first point where it could be retained is a uretero-pelvic interface, which is called juxtapelvic portion. Then we have a second. The second is in vasa iliaca. And the third is in the pelvic region, juxtavesicle. The last one, the fourth, not too common, is when the ureter is crossing testicular or ovaric artery and vein, and there is a ureter localized between those vessels and psoas major. So those are points where we can see the stone which is migrating from kidney to urinary bladder. And probably you remember my words from the start of this lecture. When the stone is traveling here, where the pain is irradiating. The pain is irradiating this way to the groin, to the scrotum, to labia majora, or middle or medial aspect of a proximal femur. Ureter has very interesting blood supply, and in comparison to the kidney, it has several levels which are anastomosing. The first level is from renal artery, then it is from testicular artery, separate rami ureterici from abdominal aorta, then also common iliac artery, and multiple from internal iliac artery. So those levels are anastomosing, and then those multiple anastomoses make possible to cut the ureter and to perform anastomosis. It's important that surgeon is able to cut the ureter and reimplant it into the some other structure, reimplant it into the urinary bladder. It could make new bladder from small loops. It could also to implant it to the skin, etc., etc. So surgeons here are not limited too much in position. And also it's important when the surgeons implant transplanted kidney. Then the ureter could be implanted into the urinary bladder. So varieties of a collecting system. This is a IVU, intravenous urography, and is showing to us that there is one and there is a second collecting system. Also here on the other side you can see two systems. So it's called pelvis duplex. Then we could have also not only pelvis duplex, but twice ureters. When ureters are entering urinary bladder, typically when they are going up to level of urinary bladder, we talking about ureter duplex. Duplex ureter, the upper one, is connected with lower position. This is a duplex. What is fissus? Fissus is then somewhere fused in one. Why are we talking about it? The infections of urinary system are very, very frequent. Those infections are one of the most frequent, except probably respiratory it's the second frequent infection. And all those variabilities, all those are prone to have infection because the maintain flow of urine is not properly equipped with the muscular layer, etc., etc. So now we turn to urinary bladder. Urinary bladder is a sac which is collecting urine, and the sac has capacity about 300 milliliters. 300 milliliters is approximately normal volume. It could be enlarged, it could be decreased, and then second very important is that the urinary bladder is localized in the front of peritoneal cavity. It's localized behind symphysis, and then above symphysis it could be performed section which is called sectio alta. The sectio alta is the scission of the abdominal wall, and preperitoneally, without opening of peritoneal cavity over symphysis, you can open the urinary bladder. From the urinary bladder is arising ligament which is in midline going up to the umbilical region and is called ligament umbilicale medianum. I will note something about it. Then we have an apex, corpus, and fundus. And urinary bladder, how it's inflated by the urine, could expand, and in some pathological situation you can palpate urinary bladder in the level of umbilical scare, especially when patients have so-called outflow obstruction. In some patients who could have enlarged prostatic gland, typically in some male with inveterated disease. Urinary bladder is fixated to the abdomen only in 2 points. One point is urethra, and urethra passing through the perineal membrane, and the second is band of connective tissue which is called ligamentum pubocysticum or puboprostaticum, because pubos prostaticum is in male, containing also prostate inside. And when you can imagine what could happen when the patient is driving a car and in a car crash, in the impact in a velocity of 80 kilometers, 130, etc., and the urinary bladder is full of urine, then you can see that this is a very important point where could be the injury of urethra in this cystico-urethral junction. And also the second thing is, because it is behind the pelvic bone, the fracture of a pelvic bone could affect also the urinary bladder, or when the compression of a fulfilled urinary bladder could lead to rupture into the peritoneal or extraperitoneal space. So this is a very important consequences in mechanisms of injuries in the abdomen. So I have said that from the apex is rising ligamentum umbilicale medianum. This is a remnant of so-called urachus. So urachus is a part which is connecting urinary bladder with allantois, developmental space where the primitive urine in a fetus is excreted. and in this ligamentum could be somewhere also developmental cysts, urachus cysts, or it could be here a long process of a urinary bladder going to the ligament. And it's important that here are very special, very aggressive tumors, which are called urachus remnant tumors. So this is something else than the urinary bladder. The urinary bladder itself has apex, corpus, fundus, and is differently arranged in women and male with urethra, because in male we can see here prostate. The wall of the urinary bladder is made from 3 layers of muscles, and you can see the arrangement of muscles, and in the bottom we can see this conic structure, which is a sphincter of urinary bladder. The arrangement of muscles is important because if you can imagine that there is an increased size of prostate, probably you know that prostate problems in elderly males are very, very frequent. The outflow of a urine is not such an easy process like in a younger male. Then the hypertrophy of these muscular structures leads to hypertrophy, and we can see very thick with folds equipped wall of the urinary bladder. The arrangement of inner structures, you could see that the space of a urinary bladder is inflated upwards, but at the bottom we can observe a trigon. This is called trigonum vesicae. This trigonum vesicae is made from 2 ostia of ureters, and down is the third point, which is called ostium urethrae. So this trigonum is in the base of the urinary bladder, and we can see here how the ureters are going here. The ureters passing through the muscular layer in an oblique manner. So this is a typical course of a ureter, and urine is going to the urinary bladder. And here we have a muscle. During 2 situations, this mechanism could protect the flow of urine back to urethra. When the patient has inflated, overfilled urinary bladder, you can see that this distension could close this one. Also, when the patient would like to perform miction, the contraction of a muscle again is closing this part. Only peristaltic wave could push urine, spindle of urine into the urinary bladder. This is an important protection against the backwards spread of infection. This protection is sometimes impaired in some patients, typically in some children. You can observe multiple recurrent infection of urinary system, and it is caused due to that this mechanism is different, because if you have a perpendicular course of a ureter, then what's happening when it's inflated? When it's inflated, this is opened, and the urine could flow back. Also during miction, when the contraction of a muscle is here, is dilating. It's a force dilating the opening of a ureter. So this is called reflux of urine. Reflux of urine is a very, very important mechanism of recurrent infections. So, urinary bladder and its wall. Its wall contains typically tunica mucosa. Tunica mucosa is equipped with transitional epithelium. Transitional epithelium is some like this. You can see here smaller, larger, conic, tree-like cells. And it is in the normal situation. When it's increasing the size of urinary bladder, you can observe that the cells are flattened and 1x, then now the distance is x times 2. Then it is also made in folds, and those folds and loose connective tissue in tela submucosa, in overfilling of the urinary bladder, makes possible to extend the size of epithelium without any injury of it, because it could slide along muscular layer and it's flattened. So it's a like balloon. You can inflate it like a balloon. Urine is inflating urinary bladder. Tunica muscularis has several layers, 3 layers, outer, middle, and inner. The arrangement of the fibers is in a spiral manner, because like all other organs which could compress something and to inject outside or eject outside the content. If you can remember myocardium, also myocardium has a spiral manner of muscular layers. Also, uterus has the same manner. So all those organs have a spiral manner of fibers, and it could help to equip ventile mechanism in ostia. Outside is connective tissue on the surface, tunica adventitia, which follows to paracystium. Paracystium is a loose connective tissue surrounding urinary bladder. But I go back to this image. I have said that urinary bladder is mainly localized in preperitoneal space. Preperitoneal space is here, even if it is down, and on the surface of a urinary bladder we can see adventitia and then paracystium, and over paracystium is a peritoneum. So then the peritoneal coverage is present on a urinary bladder, but it is not primarily covered by peritoneum. It's only secondary, because between it we have a connective tissue. Peritoneal coverage of urinary bladder is following from the abdominal wall. Here is a ligamentum umbilicale medianum, the remnant of urachus. This is a urinary bladder. Here we have uterus. And here is a rectum. And we have excavations. Excavations which are called retrovesicalis. In rectovesical excavation, we have in women a space between urinary bladder and uterus, and the second is between uterus and rectum. And this rectouterine excavation is the lowest point in women in a peritoneal cavity, which is palpable through the rectum with digital examination. The same it is in a male, but in male we have here no such a structure, because this structure is here also something. This is seminal vesicle, but it is not prone over the urinary bladder. So in male, there is a space only between urinary bladder and rectum. The space is important not only for the fluid collection, infections, irritation there, but the urinary bladder and rectum and uterus in women have important mechanisms or important roles in defecation to make compression of also a rectum. So the emptying of a rectum is also depending on the relation of it. So this is retrovesical space. Urethra. Urethra is a tube which is the way of urine from urinary bladder to the outside. It has osseum, internum, and externum. Internum, it's in urinary bladder. Outer osseum is different in a male and in a female. In a male is at the tip of a glans penis, and in a woman it's between labia minora, above the osseum of vagina. Tunica mucosa is made by transitional epithelium in the proximal part. In the distal part, lower part is multi-layered squamous epithelium. It contains also submucous, muscular layer, and connective periurethral tissue. Urethra exactly is different in male and woman. It's clear. In male, it's about twice as long, and in women, it's a straight. Both genders have problems with urethra. In women, urethra is a short, and this is a short way for infection from outside to inside. In male, the problem is that very frequently somewhere here or here could be stenosis of urethra, and it could perform the obstruction of outflow of urine. And also during catheterization of urinary bladder, there are some points where the catheter could perform injury. So then it's clear here, and the obvious practical approach is that in women could catheterize urinary bladder nurse because it's easy. Not only easy, it's safe, and in male it's a doctor. So it's important. And I hope that you will have possibility to try it here in a simulation center and then in a real patient. So it's a catheterization, feminina and masculina. Male has here prostate, and then up to this level of up to perineum, this is the only difference in a prostate. But the general composition of those structure is very similar. But in female, we can observe here also something which is called skene gland. And the skene gland is a female prostate in general. And we can observe in some women, but it is not rare. Now we know it from magnetic resonance, it is very frequent, that those women could have not the same, but similar problems with hypertrophy of this gland like in male. And also there is possibility to have their prostate cancer in in the scanner gland. So it's a rare but possible. So remember that everything is possible in male and woman, vice versa, because all tissues are developed the same way. Only different is the stimulation during development. So then, if you look for those muscular structures, those muscles are very similar in male and woman, but between those two levels are in male prostate. Feminina. It's a short 3 to 4 centimeters. It has 3 parts. Intramural part, which is in a part where is a cone of outflow from urinary bladder. Then is a pelvic part, short part, and the last part is the perineal part, which is passing through the perineal membranes. Perineal membrane is composed of muscles and fascias. And it has sphincter urethrae. Sphincter urethrae is made from smooth inner layer and stripped outer layer. In comparison to the muscle, which is localized in the ostium internum, so it's a sphincter vesicae urinaria and is made from smooth muscle. In the urethra, we can observe small glands which are called uretrales, and they are producing mucin and mucinous layer inside protecting tissues from maceration from urine, because urine is an osmotic and then also chemical active substance which could impair the mucosal layer. So, urethral sphincters. Sphincters in a woman, we have this is a sphincter which is sphincter urethrae internus. It's continuation of sphincter vesicae urinaria, and this is smooth. And then we have externus, and externus has 2 layers. The inner is a smooth, so it is a not voluntary contracted. And you, with your mind, could maintain the outer stripped. And you probably know the situation when you have to urinate, but you don't know you cannot. So then you can compress this layer because it is a stripped. And this is a last stent which is closing urethra. Then also it's important that we have a muscle which is called dilatator of urethra. This dilatator of urethra, I will show you it on a masculine urethra. Urethra masculina or virilis is a longer. It's a 20 to 25 centimeters long. It's a twice bowed. And then we can see here more parts than in women. We have intramural. Intramural is in a muscular layer of urinary bladder. Then we have prostatic part, which is passing through the prostate. Then is a membranous, which is passing through the membrane of a perineum, and then pars spongiosa or pendula, which is a spongious body of a penis. This penile part is the longest one. But we have a one which is the most prone to be injured. This is a membranosus. And when you can imagine that you have to insert the tube inside the urethra, this could be straight, and there is an angle. There is possible to make injury. of urethra. So in urethra, we have some important openings in male. Those openings could be seen also in a women, but in a women there are only products which are not too important. In male, we have colliculus seminalis, which is in prostatic part, where are going into the urethra openings of ductus ejaculatorius, or two ducti, and multiple prostatic gland openings. And then there are some remnants of the ductus Mülleri. In spongiose part, there are bulbourethral glands, which are opened here to the bulbus, and also multiple urethral glands. Those glands are the same like in women, so they are producing mucinous content protecting tela mucosa, protecting epithelium. So urethral sphincters in a male. We have this like cone muscle, which is sphincter urethrae internus or vesicae urinariae. Then we have an outer. The outer has two layers. Outside is stripped, and inside the green one is a smooth. This is also smooth. And here we have two other additional muscles which are important. This is a muscle, and you can observe this band is going in the anterior aspect of your urethra, and with this contraction, you can see this is relaxing, and this is contraction. And then it is opening the orifice of urethra. And then the urine could flow outside. And then we have also here muscles which are able to maintain the openings of ejaculator ducts during ejaculation or during urination, because not possible to urinate during ejaculation due to reasonable thing. So it was kidney and outflow tract. Then we have here suprarenal glands, also adrenal glands. So it's the same. They are localized primarily in retroperitoneum, inside of renal capsula, or inside of fatty renal capsula, or fascia, and is surrounded by fatty tissue, fatty adipose capsula of a kidney. Between kidney and adrenal gland is a septum made by thin layer of connective tissue. So the position of kidneys and adrenal glands is very easy to understand. The kidney at the top has two structures, adrenal glands. Here we have adrenal glands. They are quite small organs, very small organs in the retroperitoneum in comparison to the pancreas. Here you have a pancreas, liver, spleen, very small. The right has a V shape, and left one has a epsilon, or upside down epsilon shape. And you can see here epsilon and here V, or epsilon here is this one. What's seen here on those images? Interesting thing, and remember it, Only one vein is going out. And if we go back, one vein is going out and multiple arteries are going inside. The blood supply of an adrenal gland is important for the understanding of the function and structures of an adrenal gland. We have a cortex and medulla. They are different from their functions, but they are different from development. The medulla is a sympathicus or sympathicus ganglion or paraganglion. So this is something which is neuroendocrine. The other part, cortex, has a different products and different structure. We can distinguish several layers of parenchyma from surface to inner. First zone is called glomerular because it forms something like glomeruli. Then you have a fascicular part because you can see here fascicles of the tissue. And the last one is a reticular zone because it forms rete. Those three zones are cortical, and the blood flow is from outside to inside. The blood is flowing through this and taking several products. We have two retes. One is in zona glomerulosa. Then we have a capillary, more arterial capillary system, and here is a connected to venula, so capillary system in zona reticularis, and then following to venous part of this rete, and then to the veins, and this is only part which is medulla. So medulla is a relatively small part in the point of view of a volume of active tissue, but in fact it is a larger. So this is a structure. Again, we can see glomerular, so it forms some glomeruli. Then we have a fascicular, then a reticular, and here is medulla. And this is a cortex. In a cortex, it's important then in glomerular zone there are produced mineralocorticoids. The main is aldosterone. Glucocorticoids in fascicula, so the main is cortisol. And aldosterone, sexual hormones in reticular. What's important? All of those three types of hormones are steroids. In medulla, there are products which are called adrenaline and not noradrenaline, and it is the same like epinephrine and norepinephrine. In English, in US and UK, use epinephrine, norepinephrine. We in Middle Europe use adrenaline, noradrenaline, but it's the same. Adrenal gland or epinephrine is from Greek. So it's a product of sympathetic paraganglion, and those molecules are bioamines. So they are products of some amino acids, so small molecules, different action, different structure, but different, not too much different consequence. Overproduction of those and those could. What is the consequence of overproduction of those hormones? It's increased blood pressure, because all those structures producing something which is needed in a stress reaction, in a hunting and in a defense. Even adrenaline, noradrenaline, even cortisol and aldosterone. They are preparing the body for the stress. And overproduction has consequence in hypertension. Suprarenal vessels. We have 3 suppliers of arterial blood. So first is suprarenale superiores. They are multiple and they are branches of phrenic inferior artery. So the first branch of the abdominal aorta. This middle level is suprarenals media, frequently from aorta, but probably also some patients could have it from renal artery. And the last one is the suprarenalis inferior, which is in every patient from renal artery or some branch of renal artery or some polar artery, for example. Then we have veins. The vein is only one on each side. The left one is inflow of renal vein. But on the right side, it is a directly inferior vena cava. And now we can turn to repeat something about vessels at the retroperitoneum. We had it in last lectures, but I would like to draw here some images which probably you can do the same way. That we have some basic structure of abdominal aorta. This is abdominal aorta, this is a common iliac artery, this is external iliac artery, and this is internal iliac artery. This is the main branching. And then we have also one artery which is a tiny and is called arteria sacralis mediana. This is this artery here. This artery is a remnant of caudal aorta in other animals, like in lizard or in cat or in keporkak. Then aorta has important branches, impaired visceral vessels, impaired visceral branches. We have abdominal aorta, and here we have one first. First one is a celiac trunk. Celiac trunk is divided in 3 vessels. One is going to the spleen, arteria lienalis, lienal or splenic artery. One is left gastric artery, one is common hepatic artery. Common hepatic artery has a branch which is gastroduodenalis. And then is going to the liver, and it is a proper hepatic artery, arteria hepatica propria. Next artery is called arteria mesenterica superior. Superior mesenteric artery is going to the right side and arising here branches for ileum, ileum, multiple. Then the last is ileocolic artery. Ileocolic artery is supplying terminal ileum cecum. And then we have here two important branches to colon. One is right colic, the second is middle colic artery. And I now use pink or purple to draw inferior mesenteric artery. An inferior mesenteric artery has several branches. One is a left colic artery, and left colic artery is then somewhere here communicating with middle colic artery. Then we have a sigmoidal artery, and then we can have here inferior rectal artery, or better, like here. And here we have a communication. I use green one. This arcade is a communication between superior and inferior mesenteric artery, and this communication is called also riolan, anastomosis. So this is the main schema of abdominal arteries. When you are able to draw it, you can understand how the blood is circulating in bowel. So those are impaired with arteries. Then we have a paired. So impaired are only one. Paired are twice. Abdominal aorta has those impaired to the gastrointestinal organs or gastrointestinal original organs like spleen, pancreas, gallways, liver, and paired are for urogenital tract. So those pair are renal arteries. We know that they could be multiple. Then we have a suprarenal artery, but in general it is only medial part, because the other are from phrenic artery, renal artery. And then we have testicular or ovaric arteries. And please remember that they are arising from aorta below renal arteries, but in upper part of the abdomen. And it has important consequence because the same arrangement is for veins and the same arrangement for lymphatic vessels. So the outflow from inner organs, if you can hear testes and ovaries, is outflow of lymph is along those vessels to the upper part of retroperitoneum, or middle or upper part of retroperitoneum. And the drainage is not into the pelvis, even they are localized in pelvis. Then we have a parietal branches. Parietal branches of aorta are also quite simple. We have phrenic arteries, phrenic inferior, then we have lumbar, and then we have iliolumbal. And the last one is a sacralis mediana. So you can see here 1, 2, 3, 4, and probably 1. Here more. So those lumbar arteries are supplying wall of the abdomen. So inferior vena cava. Inferior vena cava has a similar arrangement like abdominal aorta. It has two sources, which is common iliac vein. This is external iliac vein and internal iliac vein. It constitutes inferior vena cava, but if you can see it here, here is a space where common iliac vein on the left side is going between aortic branch, common iliac artery, right one, and between spine. Then it could be compressed. And it is called nutcracker syndrome because the vein could be compressed and here could occur thrombosis of the vein. That's not too rare syndrome because it's compressed and then the patient has hypercoagulating state after deliverance, after some surgery, after some congenital factors. So then it could occur here thrombosis, more frequent on the left side. Then it has some intakes. So those are testicular and ovaric veins and renal. So those are renal. And testicular vein and ovaric vein from the right is going to the inferior vena cava. From the left side is going to the renal vein. And also suprarenal. On the right, we know it's directly to the vein. And on the left, it's also going to the renal vein. Why it's so strange? We have something which is called ascendant lumbar venous system. The aorta is only one artery which is leading blood into the lower part of the abdomen. The other are very, very small, only in the anterior chest and abdominal wall. There is a very complex system of veins which are developing during fetal part of development, but the rest of this development is in our venous system only inferior vena cava. But there is a developmental second vein which could be here. Sometimes there is no fusion, and this is a inferior vena cava sinistra. In most of people there is nothing. In some there is a two duplex vein and the blood is flowing through the renal vein to the common inferior vena cava. The next system is along vertebral column, and they are two ascending lumbar veins. And those are connected with lumbar veins which are going from lateral part, and they are also bridges to the system of inferior vena cava. And everything is connected together like a web. And in general, when we look at the system has three outflows from retroperitoneum. One is inferior vena cava, the second is vena azygos, and the third one is vena hemiazygos. Then it is a connected with azygos, and then partially the blood flow from lower part of the body is through the superior vena cava. And those connections are very important connections which are called cavo-caval anastomosis. Yeah, and it's important when the patient has a thrombosis of an inferior vena cava. If you have here blocked blood flow, the blood then could flow through those vessels. If the tumor from a kidney is growing into the vessel, if the tumor from a liver is going into the inferior vena cava and obstructed those vessels, the blood flow is then possible through those collaterals. Nervous system in the retroperitoneum is also arranged, very complicated. And we know that we have here some supplies from parasympathicus and sympathicus. Parasympathicus is going here from vagus and in a sacral region in S2 to S3. And sympathicus is supplied by splanchnic nerves from thoracic and lumbar ganglia of a sympathicus trunk. And here we have some structures which are forming ganglia. Those ganglia and also plexus are connecting organs with autonomous innervation. The main suppliers are plexus phrenicus, splanchnicus major, minor, but other in the other. And in the upper retroperitoneum, we can observe the conglomerate of ganglia, which are ganglia celiaca, and forming also plexus solaris. Then we have ganglion mesentericum superius, and the second is inferius, somewhere near. And then we have aorticorenalia and renalia ganglia, and those are perivascular plexuses which are going into the kidneys and also into the suprarenal glands. What's the main function in comparison to the gastrointestinal tract? You know that in gastrointestinal tract sympathicus and parasympathicus is important. But sympathicus is something which is improving perfusion due to contraction of a vessel, increasing blood pressure. So the sympathicus is importantly increasing the perfusion and the pressure inside the kidneys, and then filtration of urine. And the second thing is that I have said that adrenal glands are sympathetic paraganglia, and there is a stimulation of sympathicus to the neuroendocrine cells which are able to release adrenaline or epinephrine and noradrenaline, norepinephrine, stress hormones. So this is the important web which is here seen. The supply of it is mainly from the segment in which is lying this system of renal and adrenal glands. So this is about L1 to L2 supply of probably sometimes TH12. So the middle or lower part of a sympathicus. So last note about lymph nodes. I have said to you about those lymph nodes. So important is that in the retroperitoneum we have an ascending lymphatic system which is leading lymph from lower part of the body, from lower extremities, from retroperitoneum, from pelvic organs, but also indirectly also from gastrointestinal organs. The arrangement of lymph flow is that the lymph is going this way from the right part, and you can see that from right part there is a connection to the 3 territories. So right are also paracaval, those are paracaval, and those interaortocaval, but if you have some drainage from right one, it could be also in the left part of retroperitoneum. So the tumor which is affecting the right part of the pelvis could has here lymph nodes. The interesting is the curse of a left. You can see here the way of lymph, and is rarely into the interaortic, but never in a right one. So this is important. And then it's important to know that there is somewhere, this is a testicular artery and testicular vein, and the lymph way from testicular tumors. So it's a very frequent tumor in a younger male is a seminoma or other some embryonic tumors of a testis. And those people, you cannot palpate any metastasis in the groin, never. Never observe in the pelvis. And frequently, first line of metastasis is in a middle and upper part of retroperitoneum. So remember it. This is example how it works. If you can see there is no metastasis in lymph nodes. The tumor is here. This is a tumor of a uterus, corporal uteral tumor, carcinoma. Not too frequent, but relatively not rare tumor. And lymph nodes are here, because here we have supply of a uterus which is from internal iliac arteries, and also there is a supply from ovaric, and also here. So you can observe that the main portion of the lymph nodes are on the left middle part of a retroperitoneum below renal veins or renal vessels. So remember it. Yeah? You can use it every time when you will have a question about tumors of a uterus, ovary, and testicular. So then the drainage is to the upper retroperitoneum. So it was everything about those organs and the retroperitoneum. Next time we will have a lecture about pelvis.